Hi, this is Becky Sanders, Program Director for the Upper Midwest Telehealth Resource Center. And today we have Stephanie Laws with us. She is the Executive Director of the Rural Health Innovation Collaborative. Stephanie, I'm going to go ahead and hand it over to you.
All right. Well, thank you, Becky, and welcome everybody on the call. This is a very relevant topic, I think, for all of us today, and I'm very pleased to be able to present it. Next slide, Becky. So obviously, for those of you who are on the call that are really knowledgeable about the grant world and putting together those needs assessment, you are not unfamiliar that the obstacles faced by healthcare providers and patients in rural areas are vastly different than those in urban areas. Rural Americans face a unique combination of factors that create disparities in healthcare not found in urban areas. Economic factors, cultural and social differences, educational shortcomings, lack of recognition by legislators, and the sheer isolation of living in remote rural areas all conspire to impede rural Americans in their struggle to lead a normal, healthy life. Some of these factors that present health inequities include high blood pressure, cardiovascular disease, diabetes, our suicide rates, death from serious injury. Most relevant in the news at this point are those polysubstance abuse factors and opiate overdose issues, but the list can go on and on. And those health inequities are sometimes as the direct result of barriers to sustainable, accessible, affordable, and available health care. Next slide, Becky. So given this inequitable balance of having a good representation of rural and research and the inequitable health balances that exist, it is so important. And I'm going to take this quote, and I actually got this quote off of the Rural Health Research Gateway, that the emphasis of knowledge translation is to ensure health providers, consumers, researchers, advocates, and policymakers are aware of, can access, and are able to use health research findings to inform decision making. It is important that we have strategies that allow for equitable representation of our rural communities, have those political advocates, and also facilitate policy promulgation. Next slide, Becky. To talk a little bit about rural research in motion, and we will get to a specific case example of research that our organization is currently undergoing now. Sorry, I don't know why there was a cutout there. Oftentimes, we know that there is a separation of evidence-based practice and clinical practice in rural healthcare settings. Oftentimes, this translation of evidence is usually adopted by clinical measures or performance measures that are mandatorily or voluntarily collected and reported to agencies such as the Centers for Medicare and Medicaid Services. Obviously, this is a more reactive-based model that drives process change in clinical practice. And I want to be sure that I note here, being a former clinical provider in a critical access hospital setting for the majority of my professional career prior to transitioning over to telehealth and my other roles in 2008, this by in no means, shape, or form is intentional. Multiple competing priorities exist, ranging from bedside to administration, operations, and financial performance. There are so many pieces of that equation being thrown at very minimal resources when it comes to all of those components that go into running a seamless organization, that it is very admirable that such a great group of people in all of these critical access hospitals, federally qualified health centers, and rural health clinics can do that with passion and conviction. In another sense, there are recent movements in accreditation, special accreditation standards, such for stroke centers, baby-friendly hospitals, and trauma centers, which also drive translational practices to the bedside. So, you know, as we go out and we work with our respective sites with telehealth, these are some of the things that we have seen that have impeded translational research in those settings. So if you go to the next slide, I think it's important to point out that the Federal Office of Rural Health Policy currently funds 8 rural health research centers, and there are 3 rural health policy analysis initiatives. It is so important that the audience know where they can go to go get additional information and resources. The Rural Health Research Gateway provides easy and timely access to research conducted by the Rural Health Research Centers funded by the Federal Office of Rural Health Policy. The Gateway efficiently puts new findings and information in the hands of their subscribers, including policymakers, educators, public health employees, hospital staff, and more. You don't have to know it all. You just have to know where to get your information and your resources. I have also listed on this slide the different rural research centers that are currently funded by the Federal Office of Rural Health Policy. Each of them has a specific aim and scope around their research. And if you go to the Rural Health Research Gateway, mouthful, you can learn more about each of these centers. So, telehealth research in motion, you can go ahead and skip to the next slide. I am going to talk about how rural research and those obstacles, barriers, challenges, and opportunities exist in a specific project that I am part of here in the Wabash Valley region in Indiana and Illinois. This initiative, funded by the Health Resources Services Administration, Evidence-Based Tele-Emergency Network Grant Program, is a collaborative effort between Union Hospital and its Richard G. Lugar Center for Rural Health, the Upper Midwest Telehealth Resource Center that is under the auspices of the Indiana Rural Health Association, and then our research partners at Indiana State University. And I am very pleased to share that as part of more of the broader scale initiative, we have finalized our agreement with one of the 8 federally funded research centers through the University of Iowa, or RUPRI, as part of this initiative. So very excited that we will be finally partners with the Center for Rural Health Policy Analysis. Just go to the next slide. So as I mentioned at the beginning, you don't have to know everything, but you have to know your resources. And as you can see listed here on this screen is our grant project team on the local level. So it takes a lot of resources to be able to facilitate and foster not only the grant and the project, but also the research that is part of the components of the work plan. If you will go to the next slide, you can learn more about our collaborating partners as I start talking about what it is we're doing. So we have many recipients of the grant services that are running telehealth services in their local emergency departments. We have emergency care providers, and then we also have grant and evaluation management support. Next slide, please. So just to give you a little bit of background, Union Hospital's Richard G. Lugar Center for Rural Health was awarded this HRSA Evidence-Based Tele-Emergency Network grant. It's a 3-year grant totaling around $1.2 million. We are one of 5 other grantees in the United States. I've also referenced our grant number at the bottom of each of these slides if you have any reference to the question, but in compliance with the HRSA and our advertisement of this funding. The purpose of this 3-year grant is to generate a significant number of patient encounters to evaluate patient and provider outcomes and cost of teleemergency services in rural emergency departments. And moreover, contribute to a broader scale analysis with the University of Iowa and RUPRI to look at that across all telehealth grantees nationally. We feel that this contribution to the body of literature will help inform not only our lawmakers, but also our Congress as they look at budgets and looking at the Office of Advancement of Telehealth, and not only that, helping to reduce the inequitable balances found between rural and urban communities. If you'll go to the next slide, the outcomes that we hoped to achieve is that we want to facilitate optimal patient health outcomes. First, do no harm. What we have been so successful at is a seamless integration of telehealth within the clinical paradigm, so that telehealth is largely viewed as a tool to help facilitate connection and not replace entire clinical processes. We also want to help educate emergency care providers regarding telehealth competencies. And we want to sustain our rural healthcare facilities. Obviously, when you look at critical access hospitals across the nation, sometimes they are the largest employers within those regions. Being able to keep market share on a local level that can safely stay at a local level is very important, and telehealth can help bridge that gap in some instances. We want to discover where costs may be neutralized or reduced with telehealth, whether that be with transfers. We want to share data, outcomes, and dissemination opportunities with other national sites via HRSA's collaborative agreement and activities associated with the University of Iowa and RUPRI. Next slide, please. The focus of our study has 3 main clinical domains, including teletrauma care, neurology, and behavioral health. Next slide. First and foremost, as we began our journey to conducting not only the activities portion of the programmatic impact with our rural partners, we also needed to start a rural research journey with our partners. The project team is very sensitive to the limited resources of our collaborating partners. As I had mentioned in a previous slide, there are many passionate individuals wearing multiple hats in our rural critical access hospitals, and they are just doing such exponentially great work. But the more that we add on to them, we have to make sure that not only it is a priority, but it is also something that we can expect for them to also integrate into their daily activities. We also assist in data collection processes by focusing on data that's already being collected to minimize that impact on manual data abstraction. We work closely with each recipient hospital and collaborating partner, just communication back and forth. How's it going? I'm not seeing surveys coming back from you. What can we do? Is it a reminder? Is it a human process issue? Is it a workflow issue? We also ensure the needed supports provided as it pertains to program implementation and the research-related activities. And again, that is ongoing. We continually thank our partners for their willingness and ability to participate on this very unique and nationally recognized journey with us, because without them, we would not be able to contribute to the great research that is being done on a larger scale outside of our local efforts. So, next slide. When the project team came together, we had to think about what the patient participation was, because we still have, at the end of all of this equation, is a patient involved in this scenario. Patients also have the right to not participate in these experiences. So, first and foremost, when we looked at this and when we talked to our recipient hospitals, the telemedicine consult must be ordered by the attending physician. Now, when I say telemedicine consult, I want to clarify the point that I am talking about a bidirectional live video interaction between a provider and a patient. The telemedicine consult to be included in our study has to come from one of the three main focus areas that I discussed with you earlier that we are looking at: trauma, neuro, and behavioral. And it also is determined to meet inclusion criteria. So what does that mean? Next slide. So to be included in our study, all patients had to be over 18 years of age or older, and they have to have that order. They are considered to be included after they complete a short survey, if they're able, following their consultation experience. And for emergency cases, family members can be asked the short set of survey questions. Next slide. So this just kind of goes over exclusion criteria. So how do you get in the study? How do you fall out of the study? So if they're a pediatric patient, if they refuse, if they have a high blood alcohol content, if they're unable to communicate or interact, with some exceptions to our teletrauma process, and then severe cognitive impairment. So if it was a behavioral health case or a neuro case, we need to make sure that we're collecting information in our most efficacious fashion. Next slide. So we also complete an inventory for tele-emergency care, or an ITEC, on the local level. This is a 2-page survey that is Likert type. And this is just, again, some of the language that we have on our survey, that it's a voluntary survey about their telehealth visit. And so we are getting some good information about the value of telehealth in our patients' experiences. So if you'll go to the next slide. Study variables that we're looking at for all cases, in addition to our ITEC survey results, which are sent back into the project team, include demographic information. Obviously, which of the 3 domains does it fit in? The neuro, the behavioral, or the trauma? Kind of that door to doc time. When did the patient come and when did the doc see them? Because that's important to understand. When was a consult actually ordered? How long was the patient in the emergency department? And how long did it take to order for that specialist to come onto the video? And then we're also studying disposition locations, such as home. Did they go somewhere else? Was it admission? Did they go to jail if it was an extreme behavioral case, or other? So those are some of the things that we're looking at. We also collect an annual socio-behavioral data on our critical access hospital ED providers. This 30-item 5-point Likert type password protected online survey was implemented during the summer of 2015 and 16, just because we really needed to understand what the perceptions were among our providers in telehealth in their clinical ED environment. Of a total of 162 providers polled who completed written informed consents to voluntarily participate in a baseline survey, 144 accessed and 134 completed, including registered nurses, physicians, and other ED providers. Year 2 participants, we're still working on those numbers. We're also working on patient data collection for matched telehealth and non-telehealth cases in the critical access hospitals. And of course, that's ongoing. We should be able to report some of those results in late 16, which we're already past the midway point, so probably 2017. And depending on the number of monthly reporting critical access hospital cases for comparison, we stated a null hypothesis for all variable relationships before analysis with statistical significance set at p less than 0.05. Next slide. For providers participating in telebehavioral and teleneuro cases, which we're alive with currently in our ED, the perceived satisfaction with telehealth delivery was associated with engagement and continuing education. The majority of participants, although, had not participated in telehealth CE during the past year. And of the surveys collected, educational preparation did not include telehealth practice experiences during their degree programs, which, you know, that might be something that we need to really try to consider. Next slide. So what predicts positive perception of telehealth outcomes? So stepwise multiple regression analysis. The overall perceptions of satisfaction with telehealth delivery and perceptions of positive patient health outcomes with telehealth, both compared to usual care, predicted if providers would recommend telehealth to family and friends. For teleneuro providers, their overall telehealth delivery practice experience was the predictor of satisfaction. And teleneuro care, I want to mention, is much newer in all of our critical access hospital facilities. Next slide. For telebehavioral healthcare providers, we have noted that their perception of overall expertise with telehealth was a significant predictor for overall satisfaction with the procedures. Overall, in the first year, providers rated neutral to very unlikely that they would recommend telehealth to family and friends, which is very interesting, and I will tell you why once we go to the next slide, because there was some interesting information that we found. Next slide, yeah. So we collect qualitative data annually from our providers. There was a major theme that emerged in year one. We had utilized traditional telehealth cards in our clinical spaces to facilitate these interactions. There were frequent technical issues being reported with setting up the live video interaction. Respondents said it took too long to set up, there was poor audio at times, poor video at times, and it was not working at times. So overall, the end user's experience was negative. They felt that there was poor and or uncollegial communication as a part of the specialists or rural providers were calling to visit, and a lack of teamwork. So this really gave us an epicenter to start working toward making improvements in year two. And I can tell you that from those lessons learned, we were able to migrate from our cart-based environment to a web-based environment, which has been a seamless transition that has alleviated all of the factors about taking too long to set up, the poor audio and video, and not working. And so I'm really interested to see the analysis of our provider surveys for year two. And then also those last two bullet points of delays in specialist response time and poor and or uncollegial communication. That is part of our ongoing strategy to meet with our critical access hospital site champions on an ongoing basis to assure that we are notified in real time so that we can work collaboratively to handle those. And so we have made a lot of great strides to overcome some of the challenges that telehealth was experiencing in the clinical environment in year one. Next slide. So it was also interesting on the conclusion that the majority of providers self-reported an average to low level of satisfaction with the telehealth delivery. You know, they aren't going to likely recommend it to family and friends, and so how are they going to be champions within those critical access hospitals to recommend telehealth? Continuing education, hands-on collaboration in the telehealth delivery is an educational imperative for providers. With the current emphasis on health technologies to enhance efforts to improve health outcomes, obviously we upgraded our technology, which is the third bullet point, to ease concerns regarding the poor connectivity, audio, video, and also the setup time for the patients and providers. And again, I go back to the relationship on the ground of building activities and or training that may need to be added for providers or telehealth specialists to provide timely and collegial communication. Next slide. So again, lessons learned is that when you're going into the critical access hospital facilities, when you talk about research, it is very overwhelming because there is such a gap, going back to those earlier slides, of translational based science and evidence-based practice to the bedside. And the other component of that is that a lot of the personnel that are working out in these rural environments have had some time and distance away from any type of academic setting. So it quickly overwhelms the system when you're talking about the engagement of end users being at that clinical bedside, at ground zero, in those emergency departments. And so continual communication, site visits, and ongoing encouragement is absolutely necessary to pull off this research challenge. You also have to have a lot of patience. The institutional review board process on the local level, contractual processes working with sponsored programs, working with providers, working through the licensing of providers if they're not licensed in the state where the telehealth is going to be performed, credentialing and privileging of providers within certain facilities. There is a lot that goes into getting the telehealth infrastructure up and running and ready to be able to participate and then contribute to research. We also had to understand that there's staff attrition that happens. And so we needed to have methods to account for that as it pertained to our data collection, our ITech surveys. Obviously, inter-rater reliability is important to research. But we have methodology in place to account for that. But again, it goes back to continual communication, site visits, and encouragement. We are also working very hard to minimize the research impact at the bedside. So right now at the bedside, that end user only has to fill out the front and the back of the ITech survey. All of the other assessment that we're working in collaboration with the University of Iowa and RUPRI, and all of our cost and those variables that I talked about earlier, I have the grants data management happening on the back end, because I can tell you when we did a federal pilot under another organization with a survey that we had put out there, we almost lost a couple of our grant partners because it overwhelmed their system to the extent that it wasn't worth participating. But we have been able to salvage them, and we were able to smartly move past and do a lot of this work retrospectively on the back end. And that especially is conducive because now a lot of the electronic health records that are out there in these hospitals with the meaningful use agenda has allowed us to have web-based access in a HIPAA compliant fashion to look at these telehealth records. Next slide. So that is the conclusion of my presentation. I know we got done a little bit earlier, but I just wanted to really have the opportunity to have questions and answers with the participants, because I know that I saw some names on there that has a lot more research experience than I do, but I just wanted to share why rural research is important, a little bit of what we're doing locally through our telehealth grant, because having a representation from these rural hospitals, these rural patients, is absolutely needed to add to the empirical level base of knowledge that is out there.
All right, thanks, Stephanie. Just the one question that we have right now that we'll talk through a little bit, and go ahead and feel free to put in additional questions on the Q&A. Can you clarify the University of Iowa and RUPRI and the Rural Telehealth Research Center?
Actually, don't we have somebody on from RUPRI on this call?
Yeah, Kim Merchant. She is not going to be able to talk live. She can text to us. She just put, to clarify, the agreement with the University of Iowa is not with RUPRI, it's the Rural Telehealth Research Center.
Yeah. So that is a good point, and I wish that Kim was able to contribute to what the role that the research center has in this process, because they are they are the ones that are working directly with the Office of Advancement of Telehealth and our federal project officer with all of the grantees to pull together not only the research tool and standardize that across all sites within the grantee network, but to statistically receive those information, analyze that, and then report that back to our federal officers at HRSA.
Right. Thanks. Another question, did any of the grant funds support programmatic activities for supporting the delivery of telehealth services to rural hospitals?
Absolutely, it did. While this grant has a rural research focus, there was obviously programmatic dollars that were put in place for us to replicate existing services in new hospital sites, new services in existing telehealth network hospital sites, and also develop some new models within those contexts. So yes, there were programmatic dollars in there, because we are at the end point of this particular activity that I showcased today, trying to improve the number of participants that we're able to analyze and contribute towards the research. And so the larger our sample size, the more inferential information we can glean and make potential generalizations. But the sample size technically is small, and I guess I can share that. So for this fiscal year, we have seen around 85 cases from one critical access hospital site, and then it ranges in a range from 85 being the max to down around 30 or 40. By and large, the number one utilized service has been behavioral health, followed by neuro. And again, we're still working to implement the teletrauma initiative with our hospitals, and there's been some elements that we've worked through on the local level given the landscape of trauma center access.
I'm trying to remember, because I know all the players, if it was in the slides, exactly how many hospitals were represented for each of the services that you've talked about? Yeah,
so on the third or fourth slide is a list of partners that is up there, ranging from Union Clinton, Greene County General Hospital in Linton, Sullivan County Community Hospital in Sullivan. We've got Scott Memorial Hospital down in Austin or Scottsburg, Indiana. We've got Gibson General Hospital down in Princeton. And what's really awesome when you look at this list of recipient hospitals is that these are all independent critical access hospitals. So we're not one large system with a lot of critical access hospitals under our administration here. So it's really exciting to be able to work with all of these different organizations. And so Union Clinton, Greene, Sullivan, and Putnam all have tele-behavioral and tele-neuro services. And Putnam, yeah, I mentioned Putnam. And then Scott has neuro only at this time. We're working on behavioral. Gibson will have behavioral, and then Paris will have neuro. So, of course, that's in Illinois. So we have bi-state issues as it pertains to medical licensure and all of those pieces that follow those telehealth rules and regulations set forth, not only at the state level, but at the federal level as well.
All right, we've still got some time. Are there any other questions from the audience? Go ahead and put those in the Q&A. Stephanie, as you guys continue working through issues on the teletrauma, what hospitals do you think will come on first with that?
So we are in the current we are right in process to have providers credentialed and privileged at Union Hospital Clinton as early as next month. It should go through our medical executive committee this month. And then we also anticipate that Greene and Putnam would probably follow next in suit, as well as Greene County. And I've met with our other hospital in the region that is also pursuing trauma center status. And we have a full go-ahead politically on that front to start working with outreach efforts, because obviously it's about right time, right place, and disposition factors. And it's not for those highest level of activation cases where a patient is severely traumatized. This is for a patient who might be involved in a motor vehicle crash that maybe has some subtle pain. And because we know that a lot of our critical access hospitals are staffed with family medicine trained physicians, they just may need a quick consult to look at follow-up and disposition patterns. So I want to clarify that this is not for the highest level of traumatic activation.
Another question about slides being made available. We will be putting the recording on the UMTRC YouTube page. Stephanie, are you okay with me emailing slides?
Sure. I have no problem. I'm an open book. Please share slides all around.
All right, so we will do that.
And if there's anything electronically that Kimberly Merchant can share to help further clarify the role about the university or the Rural Research Center, RUPRI, that would be great, because I don't want to misspeak, because I'm obviously not the expert about all the great things that the 8 rural research centers that are funded through the Federal Office of Rural Health Policy contribute to, because they all have a little bit of a different nuance in their specific focus. And there actually is, Becky, and you might want to share with the group, there is a telehealth focused research center that is available nationally as well.
True.
And I also want to do a plug and a point out here too, that if there are specific questions regarding telehealth, or, you know, how have we been able to overcome the barriers and the challenges of doing research along with programmatic implementation, Becky is your go-to person through the Upper Midwest Telehealth Resource Center, and she can certainly get you in contact with a lot of resources that can help facilitate these processes, because again, it has to move past the anecdotal of telehealth is great, telehealth, you know, help. We need to start measuring and quantifying and going back to our lawmakers and promulgate policy around this. And we've just started on the cusp here in Indiana, I think.
Mm-hmm. Yeah, another question, is there an expectation for research to be published in a peer-reviewed publication?
Absolutely. That's always the end point. When you think about the end, the beginning, the number one thing that we have set for our goal is to assure a sustainable telehealth program, that all of these programs keep sustaining within these critical access hospitals that are part of our grant program, obviously. But then from the research element, yes, having a peer-reviewed publication is definitely that overarching goal as well. Not only maybe on the local level for our local research elements, but one even broader aspect, you know, among, you know, the 5 other grantees across the nation with more generalizable information coming in. That would be wonderful.
All right. If we don't have any other questions, oh, here's another one. Is there a mechanism or application already in place by partners to measure quality of the overall program? And can you provide some details on that?
Yeah, and so the quality of the overall program, we have an ITEC survey that is completed at the time of the interaction after each individual telehealth encounter. And there is an employee portion of that end user talking about the audio, talking about the video, the clarity, you know, their perceptions of that experience. It's a very small, like I mentioned, Likert type survey, in addition to the patient survey. And so then we take that very short survey that is sent back to us, which has just the identifier for us to go back into the medical record and collect the remainder of our T-part information, which is, I'm sorry, I hadn't used that acronym before, but it's our longer form of data collection on those variables about the demography of the patient, the payer source of the patient, you know, the chief complaint, and specific clinical elements that we're contributing to. So that is how they do it. And then we also have the electronic survey that we send out annually to talk about satisfaction and perceptions and performance on an annual basis through an electronic format through Qualtrics.
All right.
So that's how we changed, in essence, what we found out year one from our traditional telehealth format to be able to change to the more web-based mobile application that we're currently utilizing in our health facilities, because directly of those providers' perceptions and feedback. And that is really, I mean, it's about the voice of our partners. It has to be a workable solution.
Mm-hmm. All right. Well, Stephanie, I want to thank you very much for sharing this information with us today. I'm going to go ahead and put back up the slide with your, your contact information, just in case there's any additional questions.
Yeah, and Becky, you always have my contact information as well.
Mm-hmm.
And, you know, please feel free to reach out, because this has been a very unique experience that we have been able to put in place. And having been the end user, having been the clinical bedside provider in those settings, I can personally attest to the gap in the translation of evidence-based practice in the bedside. And having this opportunity to be able to contribute to something larger is a really big deal. And not all rural facilities and critical access hospitals can say that they were part of such a thing. But to be able to balance it and management with the daily activities when you're working on a shoestring of resources is probably the most imperative component to ensuring project success.
One final question here. Are survey results available for public, and can you provide a reference?
I will have to check with our research team about our data usage and our ability to publish that. I'm not sure, since we haven't finalized those results. We've just got them in draft and preliminary format, just what I kind of shared here with you on these slides today, if they would be willing to share. But what we could do is connect the person that was questioning that directly with our researchers, our epidemiologists and our lead healthcare researcher.
Okay. Very cool. Well, thank you very much. And I'll send out an email to everyone with the slides and the link to the recording once it's posted on our YouTube page.
That sounds great, Becky, and thank you.